Prostate cancer is unique to males because women don't have prostates. It is a gland that sits in between the bladder and the rectal region, and basically it's a gland that allows lubrication to some extent. Unfortunately, the vast majority of men, the older you get, the more likely for you to develop prostate enlargement and oftentimes, unfortunately, develop cancer, which is basically a growth within the prostate gland. I like to tell my patients that the most important part once you've been diagnosed with cancer is to actually identify the right team of people that you want to work with, whether that is a surgical team, a radiation oncology team, or a medical oncology team. I believe that patients with high-risk prostate cancer or with what I call locally advanced disease or advanced disease do require a multidisciplinary approach, which means that not only one treatment, but that is a group of people offering multiple lines of therapy that can actually improve outcome. So I always believe that second opinions are super important when you've been diagnosed with cancer. Even if you're comfortable with your doctor, you still want to see someone to actually help you understand a bit more. I would think of prostate cancer in three different ways: patients who have localized disease, patients who have locally advanced disease, and patients who have advanced disease or incurable disease. So for men with localized prostate cancer, meaning that the cancer is confined to the prostate gland, the standard of care in the United States is actually a bit more complex than one single treatment. Includes radical prostatectomy, which is the surgical removal of your prostate gland. For men with localized disease, improvement in technology has allowed us to actually do minimally invasive surgery. So a lot of people now are doing laparoscopic prostatectomies or using the robot Da Vinci to do prostatectomies. It can also include radiation therapy, which is basically giving you radiation from the outside, a so-called external beam radiation therapy. Or also you could receive what we call brachytherapy or SEEDS, which is basically radiation therapy, but done internally. Basically what you do is you actually put seeds of radiation in the prostate gland, then they get released over time, and that actually does the radiation instead of getting radiation from the outside. There are many other techniques, many other treatment options that men could actually explore. Those include HIFU, which is high intensity frequency ultrasound, which is FDA approved in the United States. Cryotherapy, which is sort of freezing your prostate gland with a ball of ice, if you will. And perhaps, although not a treatment choice, active surveillance has become part of what we do in the United States, which means that there are selected men who have low, indolent, not aggressive prostate cancer that can be considered for active surveillance, which means that we're going to follow you without intervention, and at any given time, if things change, we may actually intervene. For men who have locally advanced disease, which is disease that actually is still localized to the prostate gland, but by virtue of their features, can actually, one aspect them, we may find disease outside the prostate gland, but locally next to the prostate gland, where it is the seminal vesicles, which are a couple little glands that sit underneath the prostate gland, or is involving the core of the gland, or even in the lymph nodes, then the standard options change a bit. And they may include surgery, they may also include radiation therapy, but oftentimes includes the combination of both either systemic therapy and local treatment. And for men with advanced disease, the standard of care is suppressing the testosterone production. Testosterone is the major fuel that drives prostate cancer growth once you have it. So the goal is what we call castration, which is a harsh statement for most of us. But the reality of it is the goal is quite simple. We want to remove the fuel that is feeding your cancer cells. That fuel is made in the testicles, and therefore the goal for us is to suppress that production. That can be accomplished in two ways. One is surgical castration, which is basically the removal of both testicles, or the other way, and probably most commonly utilized now over the last 2 decades or so, is medical suppression of testosterone, which is basically you get an injection either monthly, every 2 months, every 3 months, however we do it, then suppresses the testicular production just by virtue of blocking the signal that goes between your brain and your testicles, telling the testicles to make testosterone. Only until recently, perhaps actually the last 2 years, the standard of care has evolved a bit, and now for selected men who have significant disease outside the prostate gland, we offer them not only suppression of that testosterone production, but also upfront chemotherapy with a treatment called docetaxel. We recognize that one treatment doesn't fit all, meaning that the same chemotherapy may not work for 5 different patients. And the biggest question that we have right now, not only in prostate cancer, but certainly in oncology, is how we can do a little bit more of what we call precision medicine, which is I want to understand your disease and I want to actually treat you based upon your makeup, not what happens to 100 other people. Every man who dies with prostate cancer or from prostate cancer, they do so because they develop this disease called castration-resistant disease, which is simply defined by you not making male hormone and your PSA going north, or you developing symptoms from your disease, or your scans are changing despite the fact that you don't have male hormone production. So when that happens, we have over 6 lines of therapy approved in the last 5 years. We have powerful oral agents that are able to block adrenal production of hormones that mimic testosterone, that can go and activate the antenna and leads to cancer growth of the prostate. We have oral agents that block that antenna directly. We have newer chemotherapies that are also effective. They lead to survival improvement, meaning make people live longer, control symptoms effectively, maintain quality of life, and control disease progression and delay the progression of disease. And more recently, obviously, we have radionucleotides that are agents that actually are specifically designed to target bone disease, also with survival improvement. And there is immunotherapy, which is what probably the hottest topics to speak today in solid tumor oncology, and an agent that actually works through the immune system to improve your survival, to improve your ability to live longer. I think a particular website that I find reliable is cancer.net, where patients can actually really go and understand, basically the entire scope of prostate cancer, from diagnosis, how do we define the disease, how we manage the disease, treatments, and also opportunities for them to understand a little bit more about their illness.